my field of research is going into changing behavior, of changing performance of people in their daily life, so in the place where they are. And what I want to do with you is to tell you a little bit where we are and where we go to. First, to introduce myself, I'm coming from the Netherlands, which is the very small spot here on the screen, making the Netherlands a little bit bigger. I'm on the eastern side of the Netherlands, and there I work at the technical university. I'm not a technician, I studied human movement science, and on the other hand, I work at a clinic. And especially the combination of the clinical field with the technical field makes it a very interesting job for me. Looking at the university, it's quite a young university. It's from 1961. It's one of the most entrepreneurial universities. So most of the spin-offs in the Netherlands are coming from this university. So there we are very proud on. When we look at the hospital in our region, it's a very large hospital, and it has it offers broad services to all the patients in our neighborhood. But it also has specific topics of interest. For which we do a lot of research and innovation, like obesity, diabetes, vulnerable elderly, cancer patients. Every diagnosis group I saw on the posters are coming along here, I think. And for those groups, we have a supra-regional function, meaning that patients are coming from far to our hospital. And what's most striking is that we also work on prevention to keep our healthcare system sustainable. There's a large focus on having prevention. And together in this combination, our mission and my ambition is to work on technology-supported, innovative, personalized health services. What we currently do in rehab, but also in clinical fields in general, is that we look at the patients as a group of patients and we treat them like a group of patients. But what we see often also in studies is that there is a large variability between different people. And by taking advantage of the technologies we currently have, we can have much more in-depth information about a person, which enables them to give them much more personal information and also personalized health system. So that's where our research focuses on. And on one hand, we want to support the citizens in doing more self-management for their diseases or for their health, but also on the clinicians of having the decision-making. By using advantage of the technology, which is able to measure continuously, we need to help the clinician to interpret the data, because it's different than just once in a time taking a clinimetry measure or ask the patient how he's doing. We're looking at prevention. And prevention in the Netherlands, there are three types of being prevention. It's prevention, one for health promotion, for preventing you from becoming ill. The other one is for selective prevention, for those who are at risk. And the third one is for those who are being ill and you want to prevent them from having more complications or having a more burden of their disease. And our research focuses mostly on the second, the upper two of these pyramids. How is our research focused? We have different building blocks where we focus on, and on some of them I want to take you through. And one of them is, of course, the smart monitoring. And with smart monitoring, we try to get insight in the behavior, insight in the performance, and into the disease burden of the patients in as much as possible in where they are in their daily life. So not in the clinic, especially not in the clinic, but at their own situation. As we use data from different data sources, there is a lot to do on the reasoning and intelligence, because we have to convert this data into meaningful data, which we can use for clinical decision-making for the healthcare professional. But on the other hand, which we can use to feedback to the patient, to coach them and to support them. And the lowest one is focused on pervasive interaction. So once we have a kind of system and we want to coach the patient, we have to focus on that there are systems which motivate them to use, like we saw the gaming things in the posters this afternoon. And then we have two vertical pilots, which is one on the requirements engineering and the other one is on the demonstration and implementation, which is definitely also a challenge, the last one. And if I have some time, I will go a little bit in depth over there. So first I want to go to the smart monitoring of behavior and performance. And I started my research in the rehab setting, and I started doing research objectively on activity monitoring using 3D accelerometers, as we have heard quite a lot. And what I have put it here is some of the publications of my PhD students which focused on chronic pain, on patients with chronic fatigue, patients with COPD, and patients with cancer. And they all looked at the activity patterns in daily life of these patients. And what we did is that we looked at the amount of activity on the first hand. Are these patients as active as the other patients? And what you see here is the line of the controls, the red one, and the blue one is of all the patients together. And here you see the average activity pattern. And what you see here is the morning, the afternoon, and the evening. And you see that in the morning they are more or less the same. But you see a deviated pattern over the day with a steeper decrease in the patient group compared to the controls. And when we investigated the correlation with experienced disabilities in daily life, then it's especially the decline between the morning and the afternoon and the morning and the evening, which is predictive of feeling disabled. And you can imagine that most of your social activities are happening not in the morning, but are happening in the evening. So what these patients choose for is to do the things they have to do, and they are not able to have any energy left in the evening to join for social activities. Makes them feel disabled a lot. We also looked more in depth, and this is very much, took more or less the parameters we heard in our first presentation of today, where we looked at different parameters of physical activity. And on one hand, we looked at the overall activity level I just showed. We also looked at sedentary behavior, and we looked at the percentage of sedentary behavior in total time, but also to the bouts of sedentary behavior, prolonged sitting. And the same we did for moderate and vigorous activity. And it was done in a study with cancer patients. And what we wanted to see is how are the differences between the different patients, and do we see profiles of different patients to come to more effective treatments, because what we saw in rehabilitation is that not every patient has a problem with the level of activity, and they are all going into a graded activity program. So that feels sometimes like you do not need what we offer you. So making these kind of profiles, and you see them here, is that we actually discern 3 different profiles. One of the group is the group of patients who had very high levels of activities, and very high level of moderate to vigorous activity, but also lots of time in sedentary behavior. So those are the patients who peak for a moment and have to rest again, and they peak again and they have to rest again. Here you have the patients who do everything a little bit, and here you have the patients who do nothing at all. And you can imagine that these need different kinds of treatments. I will come back later on because we made some kind of personalized intervention based on that. What was also taught already this morning is that we see that how we measure physical activity is different than how patients perceive physical activity. And that's not only for physical activity, it's also for general health, for health in general. What we did here, it was one of the results of our Priscilla project, in which we asked 10,000 community-dwelling elderly to judge their health status. And we also asked them and did a performance battery test on different domains of cognition and physical health and mental health. And we saw that from the patients we have, that 40% was at least at risk of functional decline or already suffering from frailty. But when we asked these patients how they feel their health or how they judge their health, then of the group who is already frail, 33% is very satisfied with their health perception or judge their health as good, is not satisfied but have a good health. And 66% of those who are at risk experience their health as good. It's not whether they over or underestimate, as was taught this morning, but the discrepancy has something to do, because if our healthcare system stays in the way it is, and people come to the healthcare professional in case they experience problems, then they come in quite late, we think. So by having kinds of continuous monitoring systems, we can probably see earlier signs of deterioration, which might enable them to do activities and to take action much earlier by themselves than when waiting where they go to the hospital, to the general practitioner. This one I can skip because it's one of the diabetes projects in the adherence to the guidelines, and you see that there is also a discrepancy between objectively and subjectively, which makes us that it's very important that we have to take other parameters into account than just physical activity. To get a better understanding of the human behavior, we have to do more than physical activity. And what you see on the left side here is that it's also cognition. What's very important is context related. It's emotion. It's all other kinds of behavioral aspects which are important to understand the human in his daily life. And as we now have advantages of different kinds of technology, so not only wearables, but imagine your smartphone, how powerful device it is for measuring all kinds of things. By just making the screen bigger over and over, you can see whether I have eye problems. By knowing what I'm typing, you can see what my mood is. So using these kind of sensor techniques in your smartphone as wearables, but also the very slim plasters which we are currently developing, the Internet of Things, all the information surrounding us gives us a lot of information, and the system already knows that I was not alone, but with a huge amount of people today. So there you can give all kinds of information about the people and about their behavior in their context, and that's very important. And just to show you one thing which will be submitted for publication next week, so please do not used it already, is what we try to do here as an example is to get insights in cancer-related fatigue. And what we did is we made a kind of mind map for these patients in all the factors that were important for them, which were related to fatigue and which were also related mutually. So you see their depression, anxiety, the level of mindfulness, the level of social interaction, the physical fatigue, which is something else than the mental fatigue, sleep. All the parameters we have here today are related to the concept of fatigue in these people. And that is different in different situations and different for different people. And you can imagine that we cannot understand this with our human brain. So we really need computer science people here to give this more understanding on what is happening. But you see that if you made such a mind map for the different people, that different people have different mind maps, and that you also have different mind maps in different situations, depending on the context or depending in where you are. So what we are currently doing is trying to get a better understanding of this human behavior in daily life, finding new parameters for daily human behavior by taking these causal relationships between these different aspects. But more importantly, I think that we also can use advantage of these techniques to measure very slow changes over time. What we normally do in clinical environments is that we measure these people once in a while, which needs quite big changes to show. Also, the context might be different, shown by the previous one. If you do the testing, then they don't show the freezing. If you measure them in daily life, then they probably will. And one of the projects we are currently working on is the project about the diabetes type 2 patients, where we measure continuous glucose, blood glucose measure with the Freestyle Libre. We measure physical activity patterns and we measure their nutrition. Unfortunately, there is no automatic sensor for nutrition, and we need some manual input over there. And based on that, we make individual patterns, as you can see on the right side, about the different aspects on what people eat and what their blood glucose level is. And what we see currently is that patients, while they eat the same things, there are different influences on glucose level, but also in the same individual, dependent on how good you slept or what your stress level is. What you eat have different influences on your blood glucose level. By taking the advantage of the technology and knowing that in advance, we are building now a feedback system for these patients so that they know how their blood glucose level is reacting and what they have to do with their insulin intake. Another example is the rehabilitation after a hip fracture. What you see in the lower corner of the slide is how we currently follow up these patients with clinimetry once in a while in their geriatric rehabilitation. And what we did with the Fitbit, but Fitbit was not that luckily chosen because of all walking devices that people have, is that we look at how people progress during rehabilitation. And what you see here is for one person in which we had the number of steps, the active minutes, the length of bouts, but also the resting heart rate and heart rate variability. And heart rate variability is in our case a measure for resilience. Do they build up another another reserve to do the things they have to do? So these are in combination parameters which we use to monitor progress during rehabilitation. All the research we do, we directly do also usability studies in whether the sensor devices we have are suitable for the patients. And for this patient group, even a Fitbit is quite a difficult device because lots of them are having cognitive problems and doing off everything which not belongs to their life, to their body. So we are also working with patches which they can have and are difficult to put on, with smart textiles, using the creative industry and creative technology, but also working on sensor devices which we can add to a hearing aid which they probably have. So we are looking also at improvement of the devices over here. One of the very challenging projects, and I do not have results there, but we will start our trial within a few days, is about the vital threatening patients in our hospitals. Now we are currently using, I do not know whether it's the same in Canada here, you have the Muse, which is the early warning system, and every nurse has to measure it once in their duty. So you have at least three measurements a day. But what we see in the hospitals is that patients deteriorate in between the 8 hours. And some nurses do at the beginning of their shift and the others at the end. So you probably have 60 hours of time. So what we do is with health patches, we measure the vital signs which are important for them, like the breathing, the heart rate, the temperature. And we are trying to find whether we can use this continuous combination to find earlier predictors of deterioration so that we can have earlier intervention of the specialist. Once we know all this information, then we have to, our aim with personalized health is that we give the people materials and instrumentation to work on their health by themselves as much as possible, and supported by clinicians if needed. And here is when the field of psychology is being combined, because people need to change their behavior, or they need to do something which you can actually see as changing behavior. And there are lots of theory from the psychology which try to explain behavioral change, or try to see what kind of parameters are important. But what you actually can see is that there are various items which are important over here, like the knowledge of people. Are the people aware? Do they have sufficient knowledge about the importance of the behavior they have to show and the behavior they show themselves? Do they feel themselves self-efficacy to deploy different behavior? Do they have the skills to do it? Are they motivated sufficiently? Do they have any autonomy to make the decisions by themselves? Coming from a medical profession, we are very into the disease we are treating people for. But the people we have on the other side of the table are just people like you and me, with having a disease, but do not want to have the disease and want to act as normally as possible. So we have to take that into account, that the people has autonomy to choose, and that the relatedness with family and friends, but also with the professional, needs to be at a sufficient level. So we did some research quite recently with the diabetes patients in our hospital and the patients with the lower limb or hip fracture, just to see how do they score on these different items, to see where are the starting point for us for the coaching. And we see that both at the end have insufficient knowledge about their disease and about the factors that are important for them to change. If we ask diabetes patients if they know whether activity and which kind of food is important for their disease, then only 30 or 40% of them is able to mention that. And the same is for the lower limb fracture. They have no idea that exercising by themselves will influence their recovery. So all the technology-supported systems need definitely a level of education, otherwise we will not come far. Self-efficacy is also very important. It's very variable. It seems to be sufficient in a diabetes patient. They believe that they are able to do so, but the group we had here is a group who's treated in a hospital. It's quite severe diabetes with all kinds of complications. But the lower limb fracture is very low, a very high fear of falling. And another one, which I want to show you, not going to all of them in detail, is the motivation. The people with diabetes have so many disappointed treatment results already that they are not motivated for doing something which prevent them for possible complications on the long run over years. They want to do something but feel directly affected. For the low Olympics, different. They were suddenly fallen and they had a fracture and they want to go home as soon as possible, so they are highly motivated. We looked into a couple of research to see whether we can influence self-efficacy, because if people do not think that they are able to do, they will not start to change. So we did a kind of lab experiments in which we investigated how we could influence self-efficacy, first in the lab, and then we translated it into treatments in the home situation. And there are 4 different ways which are currently described in literature how you can influence self-efficacy. And one of them is letting patients experience a success experience, or vigorous feedback is showing another that he is able to do so, verbal persuasion and showing the psychological status, just giving feedback about the wearable parameters you measure. We did some experiments for the success experience, and we asked people to walk in our laboratory blinded from A to B, and they have to be there in a number of seconds. And after each trial, we gave them feedback of whether they did wrong, whether they did right, and whether they or not. And we gave them different kinds of feedback. The one group got the correct feedback, the other one got always negative feedback, and the last one got positive feedback. And what you see on the slide is the different trials on the x-axis, and afterward retention tests, and on the y-axis the deviation from the goal. And what you see is that especially the red line, the negative feedback, has the most worst results. In the lower graph, you see the self-efficacy. So if you get negative feedback, it will not improve your self-efficacy. It will lower your self-efficacy. So in case people have lower levels of self-efficacy, you should give them more positive feedback. But in the case people need to become aware of their situation, you need to give them also negative feedback that they are doing wrong. So it's also dependent of the timing of your treatment you are in, whether you can, which kind of feedback you give to the patient. And that is what we are currently using into our system, which is coming from Susan Michi, who defined 8 different strategies which you can build into technology-supported intervention using these behavioral change theories to improve patients. And we used it in the patients with cancer I earlier showed, and we gave them in a 9 weeks intervention. 9 weeks was just chosen because that's the level of number it's reimbursed in the Netherlands for these patients. And we had in all the different weeks different focuses. The first one on education, then on improving self-efficacy and motivation, and then on maintenance. And they got an automatic feedback on their device. They did it on call settings, so they got a device that measures their physical activity, and they showed on the device the progress was shown compared to their goal. And there were SMS messages or text messages on the device twice a day about how they did compared to their own goal. And once in a week they got an email message from the physiotherapist how they were doing and what is the task for the next day, next week, and to see whether they have to adjust the goal or whether the patient is fine. What we saw is that this kind of treatment is effective in 66% of the patients and lasts for more than a year, so we were quite impressive. The next step is, this is only on physical activity behavior, is that we combine all these things so that we measure behavior, performance and readiness to change, that we do more on shared decision making, because so far we did a lot of decision making done by the professional, but we believe that if the decision is being made by the patient, it contributes to their autonomy, and we do not have to set 3 calls, but 1 call at a time. And you see, for instance, for diabetes, there are lots of calls where people can work on. So once in a time will probably be more effective, and the one which they think they are more self-efficient is the best to start. And then we will use kind of apps to show them the progress. And the results of the coaching are being measured again, so they can be used. So you have a cycle of continuous evaluation of how the patient is doing. another next step, because here we foresee often blended care programs where the people have a device but also some interaction of professionals once in a week or an email contact. In one of the European projects which is currently running, it's from my colleague who's mentioned over there, is that we work on a platform of artificial coaches. And these artificial coaching, each of them has a domain of health, and they are discussing with each other about what would be good for the patient, and the patient can listen to it and he can also interfere with it. And we hope that by these kind of council of coaches, as we call the project and as we foresee, that we can have a digital coaching platform which really feels as a buddy, because it interacts with you like you interact with in normal life with humans, like in a dialogue. So that will be the results we are working on now. Looking at the user interaction, it's also an important field which came out. We started with very simple devices in just mentioning results or giving suggestions or text faces on a mobile phone, or just giving bars like red and green and yellow on a screen and giving their performance. And we asked the people how they judged it. And in different studies, and I put it on here, one is that the results are very positive if we use this kind of online intervention. It's all about online interventions in daily life or physical activity programs, not at rehab institutes, but at a web portal from their home situation. And what you see at the lowest three is one that people are very positive, would advise it to the others, that the user acceptance is good. And what is important is that higher usage is related to better outcome. But there we also had one of our problems, because what we see is that the usage of the systems you see in the upper right one is the 18 weeks we followed the patient, is that the usage, the number of patients, we started with 20 in this study, but we did numerous studies of this, that the use drops till 10 after 18, so half of the patients are falling out. So that is where HMI, so human media interaction, come in for us to make develop more motivating user interaction strategies. And one thing we work on is on gamification, which we also did in the Priscilla project, and you see on the right-hand side of the slide, is there we developed a kind of island where patients have different huts, and to go from the island they have to collect items, and they can collect items by doing their exercises. And in every hut they can do different exercises on nutrition, on cognition, on physical activity. And as long as they have the exercises, then they are able to go out of the island. The other one, this is more for computer-based trainings. The other one is a mobile training device where we have connected the activity coaching on a word fit. So the more you exercise, the more letters you have in your game. And people game at the end and can communicate with each other. We are not so far that we have done large studies on this in the added value, but we did a lot of studies into the preferences of patients for gaming, and especially the elderly people, because most of our patients are old. And surprisingly, they are gaming much more than we at our age do. They are gaming for over 2 hours and think that's a very useful thing to do in their daily life, and they really like gaming, as long as it's not very violent. It's not much competition, but together. So that were all the design criteria we used to design these kind of games. We are going a step further here in using virtual reality, but also interactive LED floors to make enhancements, environments which we can put at schools, or this one actually at the right-hand side is put at the hospital in the waiting room, where children with asthma can play with each other and are being promoted to become physically active. Then I want to make a step to the validation and the implementation. And why? Because this is something which I think it's very important to do in a proper way to come forward with these kinds of technology-supported interventions. Because what I see in practice, and especially when you involve clinicians, the first thing they say is, when will we start the randomized clinical trial? And when do we start the randomized clinical trial to show the added value? And I think that the randomized clinical trial is not a very suitable design, but especially you have to take into account that in the different stages of development you are. And what you see here, it was elaborated from a framework for Deschamps, but one of my postdoc people elaborated on it and said, you have to adapt the evaluation you do to the maturity of your technology. So in the first case, when you are having a first prototype, then do not do the randomized studies or the big studies, but just focus on technical feasibility and acceptability. And the larger you can go, the more mature the technology, the larger your project can be. But one of the things you always have to measure is like adoption. And for the adoption, we did two different main issues, and one of them is we looked at adoption over time. Because adoption is often seen as a static thing. But what we saw is that adoption changes over time. So people get more positive about technology once they have a very short experience. So then they are delighted about what it can do. But after they have used it for 80 weeks, then they become a little bit less delighted. So you have to take into account in your development that the perception change. So people need new features all over time. And that also makes clinical trials difficult. On the other side, this is the UTOUT model from Venkatesh, which is being researched for quite some years. But lately we saw that there are some other factors we need to add, and there are disease-specific characteristics which makes the intention to use. If you look, for instance, at the chronic pain patients, the catastrophizing thoughts are really hampering them from using technology. And on the other hand, what you see down there, I don't think you can read it, but there is experience being mentioned, which is experience with technology. And at the current state, we are at the phase that we are not, it's not our experience with technology, but it's the way, are we addicted to technology or not? Because no one of us, if you forget your smartphone, I will bet that most of you will go home to get it. So there is some kind of addiction to the technology, which also make whether people use it, just to use it, not because they think it's useful. So we are looking into what does technology addiction do, or how is it related to adherence. Of course, we did a couple of randomized controlled trials to show the added value of our study applications. And what you see there is it's again the results of the cancer patients, where we showed the activity program, which we call the AAF, on the upper part, and we compared it with a mindfulness, and home mindfulness, so an e-mindfulness treatment, and we compared it with just physical education, as traditionals being done. And then you see that both the dark gray are the number of patients which improve on severity, that you see that both the activity program and the mindfulness program are more effective. And the activity program is the most personalized, is probably the most effective based on that. What we see is that if you look at the systematic reviews which have been done on effectiveness of these kind of e-health applications, then you see that no one makes a distinction about for which clinical aim it's being used and what do I expect from the outcome. So everybody blurs everything together and then try to find whether it's more cost effective. But it's the question on where you use it for, whether it will be more effective, whether it will be less costly, or whether it will be just having higher accessibility of care. So that's one of the things I want to give you. And the other one is the traditional randomized controlled trial. If you consider these kind of personalized e-health services, then you must imagine that the technologies are evolving very rapidly. So that if you do a randomized clinical trials and you need a year for inclusion of your patient, your technology is outdated at the latest one. And they don't want to use it, which introduces you a bias. On the other hand, we still see preferences for patients for having a clinician done and a technology done. So the preference of patients is also a problem. And the last thing is that as we talk about personalized e-health, the intervention is being composed during the interaction between the technology and the patient. So it's not a standard technology like a medication. So it's formed in interaction. So the technology changes, the intervention changes over time. That are all not good ingredients for traditional randomized controlled trial. So in the Priscilla project, we tried another way of doing studies showing the added value. And this comes from Relton, and it's called a multiple cohort study, in which you start with a cohort. So we started with a cohort of 4,000 elderly people, which we measure on regular outcomes or continuous outcomes, depending on what you have in your study. And each time there was a new release of the technology being done, we randomized a group of the cohort to that intervention, and all the others stayed in the cohort group. And then we did, in the duration of the project, 6 different randomizations. And so we had, and 1 big cohort as a control group. And it seems to be very effective ways of doing this kind of research. What we also do is I started it that we do a lot of research in the real life, so the living lab situations. But beforehand, we start with our applications in the labs, which we have at our university. And then we have the simulated environments, as I saw at the Perform Center, where you have all the kinds of living lab 1 and partly living lab 2. And living lab 3 is the real environment. And there are other things come in, because there you have other stakeholders. So once we have shown the added value, and then I go to the last few slides, we see that there is still a big gap to come from research and development into implementation in daily practice, although we have shown the added value of these kind of systems. And one of the issues is that there are, if you talk about technology-supported services, there are different ways of working coming. The clinicians need to work in a different way because they need to use technology. Often, the benefits and the costs are not at the same place. So there are different stakeholders who have the benefits and others who have the costs. So there are lots of issues which makes that this does not come forward. And the European Commission is really looking at sites in Europe where they have brought all these stakeholders together to work together on large-scale implementation. And we also did in the Netherlands, where we call it Vital Twente, it's our Vital Twente, which is our region, where we have brought all the stakeholders together to come to sustainable implementation. And what we do there, what we have brought together is the government, the insurance company, the knowledge and education institutes, but also the large hospitals and the long-term care institutions. And we are working there on sustainable business cases for the society, so social return on investments, education programs for citizens, but also for healthcare professionals. And we support people in their projects to come a step forward. And this is something which is in Europe getting very much attendance to come to out of research projects into sustainable implementation. And if you look at the AAL projects and other kind of projects, if you do not have such an ecosystem in your region ready or in place, it's very difficult to get funding in the future. I do not know whether it's the case in Canada, but I just want to give you that this is some of the developments which is going on in Europe and might probably be the case here in Canada also. And we are building up experience on how to do this and how to have all these kind of nice e-health services really being used by the patients, because that's where we develop it for. Thank you for your attention.